Hemorrhagic stroke is the deadliest form of stroke, claiming the lives of roughly 40% of patients within just 30 days. Even with the most advanced emergency care available in modern stroke centers equipped with cutting-edge technology and specialized neurosurgical teams available around the clock, the survival rates remain frighteningly low. Unlike ischemic strokes caused by blood clots blocking arteries, hemorrhagic strokes happen when blood vessels rupture and bleed directly into brain tissue or the surrounding space. The blood accumulates rapidly, creating intense pressure within the rigid skull, compressing vital brain structures and damaging neurons through toxic blood breakdown products and severe inflammatory reactions. If you're watching this because you want to protect yourself or someone you love, take a moment right now to hit that like button, drop a comment below, and subscribe to this channel. This information could literally save a life, and by subscribing, you'll never miss critical health information that matters. Without immediate emergency treatment, including aggressive blood pressure control, reversal of blood-thinning medications, and often emergency brain surgery to remove blood clots and relieve pressure, brain herniation occurs. This catastrophic process happens when rising pressure forces brain tissue through openings in the skull, compressing the brainstem that controls breathing, heart rate, and consciousness. Once herniation begins and the brainstem becomes compressed, death is almost inevitable, even with the most aggressive interventions like emergency decompressive craniotomy, where surgeons remove large portions of skull to let swollen brain tissue expand outward. What makes hemorrhagic strokes particularly terrifying in seniors over 60 is that the risk increases exponentially with age, due to multiple factors that accumulate over decades. Chronic hypertension affecting over 70% of adults over 60 progressively weakens arterial walls through a degenerative process where blood vessel walls become thickened, stiffened, and prone to rupture. Cerebral amyloid angiopathy, where abnormal protein deposits accumulate in blood vessel walls, making them extremely fragile, affects 30 to 40% of adults over 70 and over 60% of adults over 80. The widespread use of blood-thinning medications prevents normal clotting, allowing uncontrolled bleeding when vessels rupture. Research examining age-specific hemorrhagic stroke rates found that incidence increased from approximately 10 cases per 100,000 person years in adults aged 45 to 54 to over 150 per 100,000 in adults over 85. The death rate also increased dramatically with age, exceeding 60% in adults over 80 compared to 30% in adults under 60. Here's what many people don't realize. Hemorrhagic strokes don't always present with sudden dramatic collapse. Many begin with subtle warning signs hours or even days before the major hemorrhage. These early warnings represent small bleeds or gradually accumulating pressure before catastrophic increases occur. The tragedy is that patients repeatedly dismiss early symptoms as minor problems, delaying care until collapse happens. Understanding these warnings and calling emergency services immediately is literally the difference between life and death. Let's examine 8 critical early warning symptoms that appear before catastrophic hemorrhage. Warning number 8 is sudden severe abdominal pain accompanied by nausea and repeated forceful vomiting that appears completely unrelated to what you've eaten, when you ate, or any typical gastrointestinal illness patterns. This counterintuitive symptom occurs through a specific neurological mechanism most people never suspect. Brainstem compression from bleeding causes malfunction of the vagal nerve nucleus, which controls the entire gastrointestinal tract from the lower esophagus through the stomach and intestines. As increasing pressure progressively compresses this area, the nerve begins malfunctioning, sending completely aberrant signals throughout the digestive system, causing severe symptoms that perfectly mimic acute gastrointestinal emergencies. This neural malfunction causes sudden onset of severe nausea that doesn't respond to usual remedies, repeated forceful vomiting that may be projectile in nature, and severe cramping abdominal pain that patients describe as the worst they've ever experienced. The pain is typically diffuse throughout the entire abdomen rather than localized to one specific area. Critically, the pain and vomiting don't relate to eating. They occur regardless of whether you've eaten recently, and eating doesn't worsen or improve symptoms. Critical neurological signs that might accompany this include severe headaches at the back of the head or posterior neck, progressive drowsiness where the patient keeps closing their eyes or falling asleep during activities, subtle walking instability with a wide-based, unsteady gait, slight slurring of speech or double vision when looking in certain directions. Any of these findings should immediately prompt brain imaging rather than continued focus on gastrointestinal causes. Research examining presenting symptoms of bleeding in the back of the brain found that nausea and vomiting severe enough to be chief complaints occurred in 60 to 80% of cases as initial presenting symptoms, often appearing hours before severe headache or altered consciousness developed. That would clearly indicate brain problems. Abdominal pain severe enough to prompt extensive gastrointestinal evaluation occurred in 30 to 40% of cases, with many patients initially diagnosed with digestive conditions before brain imaging revealed the true diagnosis. Warning number 7 is sudden onset of severe pain in the shoulder, posterior neck or arm that appears without any trauma or obvious musculoskeletal cause, and is severe enough to wake you abruptly from sleep in the middle of the night or prevent you from falling asleep entirely despite exhaustion. This particular symptom pattern indicates bleeding into the space between the brain surface and the membrane covering it, most commonly from rupture of a cerebral aneurysm located on arteries at the base of the brain. When arterial blood under high pressure suddenly enters this space from aneurysm rupture, it spreads rapidly through the fluid pathways traveling around the entire brain surface, down along the brainstem, and into the space surrounding the cervical, thoracic, and even lumbar spinal cord. The mechanism producing severe neck, shoulder, and arm pain involves blood directly irritating extremely pain-sensitive structures, including the membranes covering the brain, major arteries at the base of the brain, and critically the cervical nerve roots exiting the spinal cord in the neck region and traveling to shoulders and arms. When blood spreads down into the cervical spinal space surrounding the spinal cord and nerve roots, it directly contacts and intensely irritates these nerve roots, causing severe radiating pain that travels along the nerve distribution into shoulders, upper arms, and sometimes all the way down to hands and fingers. The blood acts as a severe irritant, triggering intense inflammatory responses and activating pain receptors throughout the affected areas. Many patients experiencing a small warning leak before catastrophic rupture present with sudden severe neck pain that radiates into one or both shoulders and down the arms in specific nerve distribution patterns. Tragically, only approximately 30% of patients experiencing these warning symptoms actually sought immediate emergency medical attention. The remaining 70% either didn't seek care at all, attributing symptoms to minor muscle problems, or sought care where symptoms were misdiagnosed as cervical spine problems or other benign conditions. Warning number 6 is the classic sign that everyone should know: sudden severe headache reaching maximum intensity within seconds to 1 minute, described as thunderclap headache or the worst headache of your entire life. Worse than any migraine, tension headache, or other headache you've ever experienced. This distinctive symptom indicates acute hemorrhage, most commonly from ruptured cerebral aneurysms. The pain character is absolutely distinctive and unlike other headache types. It reaches maximum intensity almost instantaneously within seconds to 1 minute, rather than building gradually over minutes to hours like migraine or tension headaches. The onset is so sudden and dramatic that patients can tell you exactly what they were doing when it started: sitting at dinner, getting out of bed, exercising, or having a bowel movement where straining increased pressure triggering aneurysm rupture. The intensity is extreme, typically rated 10 out of 10 on pain scales, described as being struck by lightning, hit in the head with a baseball bat, having a bomb explode inside the skull, or having the worst pain imaginable. Many patients describe it as feeling like their head is literally splitting open or exploding from inside. Before we continue with the remaining warnings, if you're finding this information valuable, please take a second to leave a comment below sharing your thoughts or experiences. And if you haven't already, hit that subscribe button and turn on notifications so you never miss life-saving information like this. Your engagement helps us reach more people who need this knowledge. The pain location is typically diffuse, affecting the entire head, though sometimes more concentrated in specific regions. Bleeding from aneurysms on blood vessels at the back of the brain often causes severe pain at the back of the head and posterior neck. Bleeding from aneurysms on blood vessels at the front of the brain may cause more frontal or temporal pain. But regardless of initial location, the pain typically spreads to involve the entire head within minutes as blood spreads through fluid pathways around the entire brain. Research examining headache characteristics in various types of hemorrhagic stroke found that sudden severe thunderclap headache was present as the presenting symptom in 80 to 90% of cases of bleeding in the space around the brain, 50 to 60% of bleeding directly into brain tissue, and over 90% of patients with bleeding in the cerebellum or brainstem. The sudden onset reaching maximum intensity within 1 minute and the extreme severity were highly specific characteristics, distinguishing it from other headache types. Yet, despite these distinctive features and extensive public education campaigns, studies found that 30 to 40% of patients experiencing thunderclap headache delayed seeking medical care for hours, taking over-the-counter pain medications, and hoping the headache would resolve spontaneously. Some patients went to bed hoping to sleep it off. By the time they finally sought medical care, often because the headache didn't improve or other symptoms developed, critical hours had passed during which rebleeding may have occurred, dramatically worsening outcomes. Warning number 5 is isolated severe nausea and repeated vomiting without any accompanying diarrhea, fever, abdominal cramping, or other gastrointestinal symptoms that would suggest viral illness, food poisoning, or other primary digestive illness. This symptom pattern indicates increased pressure from accumulating blood within the rigid skull, causing pressure on the vomiting center located in the brainstem. As blood accumulates from hemorrhage, the total volume inside the rigid skull increases. Because the skull is a fixed, closed space, this increased volume translates directly into increased pressure. Normal pressure inside the skull is 5 to 15 millimeters of mercury. As hemorrhage progresses, pressure can rise to 20, 30, 40 millimeters of mercury or higher. When pressure exceeds certain thresholds, the vomiting center in the brainstem is stimulated, causing sudden severe nausea and forceful vomiting. The vomiting from increased pressure has characteristic features that distinguish it from gastrointestinal causes. The vomiting is often projectile, meaning it shoots out forcefully several feet, rather than just flowing out of the mouth. It occurs suddenly without the prolonged nausea that typically precedes vomiting from digestive causes. It brings absolutely no relief of nausea. Patients with digestive illness typically feel temporarily better after vomiting, but patients with increased brain pressure continue feeling severely nauseated despite repeated vomiting. The vomiting is not associated with diarrhea, which is almost always present in viral gastroenteritis. There's no fever unless the hemorrhage causes dysfunction of the temperature regulation center. There's no clear relationship to eating. Vomiting occurs whether or not food has been consumed recently. Warning number 4 is progressive drowsiness, lethargy, and difficulty staying awake that develops over hours and progressively worsens. This ominous symptom indicates that hemorrhage is expanding and pressure is rising toward critical levels, or that herniation is beginning to compress the system in the brainstem responsible for consciousness and wakefulness. As hemorrhage expands, pressure rises progressively. When pressure reaches 20 to 25 millimeters of mercury, cerebral blood flow begins to decrease because the pressure needed to push blood into the brain falls below optimal levels. When pressure exceeds 30 to 40 millimeters of mercury, global brain blood flow becomes significantly impaired. The system that maintains wakefulness and alertness is particularly sensitive to decreased blood flow and direct compression. As this system malfunctions, patients become progressively drowsy. The drowsiness progresses through predictable stages. Initially, patients seem a bit sleepy, closing their eyes frequently during conversations. They yawn repeatedly. They drift off during activities that normally wouldn't cause sleepiness, like watching television or sitting at dinner. Family members might comment that they seem unusually tired. As pressure continues rising, drowsiness progresses to lethargy, where patients sleep unless actively stimulated and are slow to respond when awakened. Further progression leads to stupor, where only painful stimulation produces arousal, and finally to coma, where no stimulation produces meaningful response. This progressive decrease in level of consciousness is one of the most ominous signs in hemorrhagic stroke. It indicates that brain herniation is imminent or already occurring. Yet family members often don't recognize the extreme danger, assuming their loved one is just tired, had a long day, isn't feeling well, or is recovering from the headache they had earlier. They allow them to go to bed and sleep, not realizing that herniation is progressing toward irreversible brainstem damage and death. Research examining predictors of outcome in hemorrhagic stroke found that decreased level of consciousness at presentation was the single strongest predictor of poor outcome and mortality. Patients who were drowsy or lethargic at presentation had 3 to 4 times higher mortality rates than those who were fully alert. Those who were stuporous or comatose had mortality rates exceeding 70 to 80% even with aggressive treatment. Warning number 3. The symptom most commonly ignored and dismissed as unrelated to stroke is sudden difficulty walking, loss of balance, clumsiness, or incoordination appearing over minutes to hours. This symptom indicates bleeding into the cerebellum at the back of the brain, which coordinates all voluntary movements and maintains balance and posture. The cerebellum is located in the back of the skull, positioned behind the brain stem. Despite being only 10% of brain volume, it contains over 50% of all brain neurons. It's responsible for coordinating and fine-tuning all voluntary movements, maintaining balance and posture through constant adjustments, coordinating eye movements, and enabling smooth execution of learned motor sequences. When hemorrhage occurs in the cerebellum, these critical functions are disrupted. Patients suddenly cannot walk normally, staggering and veering unpredictably to one side, then the other, like someone severely intoxicated. They lose balance easily when standing still, swaying and catching themselves on furniture or walls. Walking requires touching walls for support. They cannot walk in a straight line. Turning while walking is particularly difficult and dangerous, requiring multiple small steps and often causing falls. Fine motor tasks become clumsy and uncoordinated. Handwriting becomes large and shaky. Picking up small objects becomes difficult. Drinking from a cup causes spilling. The critical feature distinguishing cerebellar hemorrhage from other causes of walking difficulty is that weakness is usually completely absent. Patients have normal strength when tested individually. They can push and pull with normal force. Speech is typically normal or only mildly slurred. Sensation is normal. Yet despite normal strength, they cannot walk or coordinate movements properly. This dissociation between normal strength but profound incoordination is characteristic of cerebellar problems. Yet because weakness, speech problems, and other obvious stroke symptoms are absent, 90% of patients and families don't recognize this as stroke. Research found that patients with cerebellar hemorrhage causing unsteady walking initially attributed symptoms to inner ear problems, dizziness, generalized weakness from illness, or simply losing balance from aging. Most delayed seeking medical care for hours or even days, assuming symptoms would improve spontaneously or could be addressed with non-urgent evaluation. Warning number 2 is sudden weakness, numbness, heaviness, or clumsiness affecting one side of the body, including the face, arm, or leg. While this symptom is well known and widely recognized as indicating stroke from public awareness campaigns, teaching face drooping, arm weakness, speech difficulty, time to call emergency services, many people don't realize that hemorrhagic stroke causes these identical symptoms just as commonly as ischemic stroke, and distinguishing the type requires brain imaging. The weakness develops suddenly over seconds to minutes, affecting the arm, leg, or face on one side of the body. The pattern depends on hemorrhage location. Hemorrhages in or near the internal capsule, where motor nerve fibers descend in a tightly packed bundle from cortex to brainstem and spinal cord, cause weakness affecting the entire opposite side, including face, arm, and leg. Bleeding in motor cortex causes weakness in more limited distributions depending on exactly which area is damaged. Brainstem hemorrhages cause complex patterns including weakness affecting both sides, or crossed patterns with face weakness on one side and body weakness on the opposite side. The mechanism involves hemorrhage directly destroying brain tissue, where motor nerve fibers travel or causing compression of these pathways. As bleeding expands over minutes to hours, Weakness progressively worsens from mild clumsiness to moderate weakness to complete paralysis if hemorrhage continues enlarging without intervention. Blood accumulation also causes surrounding brain swelling, further compressing motor pathways and worsening weakness, even without additional bleeding. Research examining clinical presentations found that sudden one-sided weakness was present in 60 to 70% of cases at initial presentation, making it the most common presenting symptom. The weakness severity ranged from mild, where patients could move the affected limb but with reduced strength, to moderate, where limb movement was possible against gravity, but not against resistance, to severe, where no movement was possible. What distinguishes hemorrhagic stroke from ischemic stroke clinically is extremely difficult or impossible, without brain imaging, as both cause identical sudden neurological deficits. However, certain features are more suggestive of hemorrhage. Hemorrhagic stroke more commonly causes severe headache at symptom onset, occurring in 50 to 60% of cases versus only 10 to 20% of ischemic strokes. Nausea and vomiting are more common in hemorrhage. Warning number 1. The most sensitive early warning symptom appearing in the majority of hemorrhagic stroke patients hours to days before other symptoms develop, but frequently dismissed as unrelated eye problems, is sudden visual changes manifesting in several distinct patterns. These include double vision, where you see two images of every object, sudden vision loss in one eye where one eye goes blind, sudden vision loss in both eyes, or visual field defects, where you lose vision in one half of your visual field in both eyes simultaneously, as if half the world has disappeared. The mechanism and significance differ by symptom type. Double vision indicates brainstem hemorrhage affecting nerves controlling the 6 muscles that move each eye in coordinated fashion. The nerve controlling the muscle that moves the eye outward is particularly vulnerable to compression from any cause of increased pressure. This causes horizontal double vision, where images are side by side. Other nerve problems cause vertical or diagonal double vision, or complex patterns plus eyelid drooping and pupil dilation. Research examining visual symptoms across all types of hemorrhagic stroke found that visual complaints of any type occurred in 20 to 30% of patients as presenting or early symptoms. Double vision was most common in bleeding affecting the brainstem, where nerve centers are located. Visual field defects occurred most commonly in bleeding affecting the back portions of the brain. Sudden vision loss indicating nerve compression from increased pressure was an ominous sign associated with large hemorrhages and poor outcomes. Critically and tragically, studies found that approximately 30% of hemorrhagic stroke patients experienced visual symptoms as initial warning signs appearing hours to days before other symptoms or major hemorrhage expansion occurred. Patients who recognized these visual warnings as neurological emergencies and sought immediate care underwent emergency brain imaging, had hemorrhages detected early while still small, and received urgent treatment, including blood pressure control and neurosurgical evaluation when appropriate. These patients had dramatically better outcomes with lower mortality and less disability than those who delayed seeking care. However, many patients experiencing sudden visual changes assumed they were having eye problems requiring routine eye evaluation rather than neurological emergencies. They assumed sudden double vision meant they needed new glasses or had cataract progression. They thought visual field loss meant they needed stronger prescription. They scheduled routine eye appointments weeks in the future. Some tried closing one eye to eliminate double vision or adjusting their glasses hoping vision would improve. Meanwhile, the hemorrhage continued slowly expanding, pressure progressively increased, and eventually other symptoms developed, forcing emergency evaluation, by which time critical hours or days had passed during which intervention could have prevented deterioration. What you absolutely must do is call emergency services immediately for any sudden visual changes, including double vision where you suddenly see two images, sudden vision loss in one or both eyes, sudden loss of half your visual field in both eyes, or sudden blurred vision that doesn't clear with blinking. These are neurological emergencies, not eye problems requiring routine evaluation. Emergency CT scan detects hemorrhage. If hemorrhage is found causing compression in critical locations or showing signs of expansion, emergency neurosurgical intervention may be life-saving. These 8 early warning symptoms of hemorrhagic stroke in seniors demand immediate recognition and emergency response. Abdominal pain with vomiting, severe shoulder or neck pain, thunderclap headache, isolated vomiting, progressive drowsiness, walking difficulty, sudden weakness, and sudden visual changes all indicate hemorrhage requiring emergency intervention. Minutes and hours matter critically in hemorrhagic stroke. Early detection allows blood pressure control, preventing rebleeding, reversal of blood-thinning medications, preventing hemorrhage expansion, and when necessary, emergency neurosurgery to evacuate blood clots and relieve pressure, dramatically improving survival and functional outcomes. Which symptoms surprised you most? Have you or loved ones experienced any of these warnings? Share your experiences in the comments below to help others recognize symptoms. If this information could save someone's life or prevent devastating disability, please share this video widely with family, friends, and on your social networks. Hit that like button if you found this valuable. Subscribe to this channel for more evidence-based, life-saving medical content that could protect you and those you love, and click the notification bell so you never miss critical health information. Thank you for watching, and remember, when hemorrhagic stroke threatens, every minute counts.